Although we like to think that there is a CPT code and modifiers for every single surgical scenario, unfortunately, life just simply doesn't fit into the mold of these modifiers and CPT codes. In this video, I'm going to talk about a situation, a case where you would have to hear it to determine for yourself why it's a dilemma on how to code for this case. So for those of you who don't know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group. At this time, I'd like to thank and recognize the modifiers who have worked endlessly and diligently to make sure that everyone has a great experience and to make sure that you are all having a wonderful time and making sure everybody's in line and there's no craziness here. I also would like to thank you all for inviting your friends and colleagues who work in urology to join this group. And if you have any questions, as usual, leave them in the comments below. Okay, let's start with this. Let's just say recently, I may or may not have had an unfortunate case of someone with metastatic female gynecologic disease. And consequently, she presented with ureteral obstruction, which is not uncommon, and I'm sure you all have dealt with this before. She comes in with hydronephrosis, likely extrinsic compression from a pelvic mass, and her creatinine is going up. She's suffering from renal insufficiency, and now it's up to you to come in and help drain that kidney with a ureteral stent. She adamantly does not want a nephrostomy tube, so you're kind of stuck. You let her know that beforehand that you may not be successful, but you're happy to try. So recently there may have been a case like this. And so she went into the operating room. I did the standard cystoscopy. As usual, you guys probably do the same thing. You try to shoot a retrograde pyelogram. And I noticed that there's a distal ureteral obstruction. There's no contrast going up retrograde, just a small amount of contrast with very hydronephrotic distal ureter, but there was no way, there was minimal contrast that was going up further retrograde. So I go in there, I put in the catheter, I try to put in a sensor wire with the hydrophilic tip, and I try to manipulate the catheter. I try to put the wire in. It still wouldn't go in. And I try to advance the A French coaxial sheath a little bit further retrograde to see if I can guide the wire in, the straight tip wire, and it still would not work. And then, okay, well, I thought, well, let's try the angled wire. So with the same A French coaxial sheath, I put in the angled wire and try to manipulate the wire. It still would not go in. And I thought, okay, well, let's try a 5 French ureteral catheter because it's softer and maybe I can get a little bit closer to where the obstruction is, and then I can manipulate the angle wire to get it through that tiny little opening, if it even exists. It's a very, very tight opening to see if I could get in that way. And unfortunately, despite multiple attempts, despite trying to manipulate these catheters and also the wire and trying different wires, I was unsuccessful, unfortunately, which is an outcome that I had warned the patient could occur. Now, you are the coder and you get this op note with all this mumbo jumbo, and how do you abstract it and how do you actually code for it? So here, that's the dilemma, right? So the procedures done are cystoscopy, right? I did a cystoscopy and I did a retrograde pyelogram. And I tried to put up a stent, but I was unsuccessful. To reach that conclusion, I put in a lot of effort relative to simple stent placement, right? Simple stent placement takes just a few minutes, typically, but she had unusual anatomy. And how do you as a coder abstract this case? And of course, anytime you do a retrograde pyelogram, fluoroscopy is performed, and I am usually the only person in the operating room working the fluoroscopy machine. I collimate my fluoro, and I'm doing the intraoperative interpretation in real time and making decisions in real time during the procedure. All right, so now you're the coder. You read the op note, and you know that there's a cystoscopy, there's a retrograde pyelogram, there's an attempted stent placement that was unsuccessful, but it took a lot of effort, and also there's a fluoroscopy. So how do you code for this case? Well, you know that there is ureteral catheterization that was done. You know that there's possibly a stent placement, but it was unsuccessful. So you got to think in terms of, okay, well, maybe some sort of modifier it needs to be used to document the effort that was used, but then that it was unsuccessful. But how do you account for the extra work, all that manipulation to try to put up a stent, all the catheterization, the wires, the different maneuvers? How do you account for that? So you're thinking maybe a different modifier needs to be used for the additional work. And of course, the fluoroscopy and catheterization, stent placement, fluoroscopy. Yeah, that's pretty much it. So let's look at this. You basically are going to end up with possibly 3 different codes if you're the novice coder, and you're going to be ending up with 3 different codes, and they are 52005, which is ureteral catheterization, and 76000, which is radiologic interpretation. Professional, obviously you need a modifier in that case because you don't own the machine, so you need a modifier, but we can address that later. And then 52332, which is ureteral stent placement. What I'm showing you here is the AUA Coding Today's bundling matrix. And this bundling matrix, you can first of all, it's a subscription service. AUA Coding Today.com is a subscription service, and within this software as a service, SaaS, you go down to the bundling matrix, you click on that, and then you end up with this screen right here, and you put in any combination of codes that you want. So in here, I know it's kind of small. I put in 52005, 76000, and 52332. And I clicked on that this was a facility. I'm looking for a facility RVU. And this is the outcome of the bundling matrix on the right-hand side. It will rank order in terms of highest RVU to the lowest RVU. So 52332 is the CPT with the highest RVU. And if you click on that, it indicates that it's cystoscopy with insertion of indwelling ureteral stent. Okay, and let's go back to the bundling matrix. This one here is 52005. And if you click on that, 52005, 52005 indicates ureteral cystoscopy with ureteral catheterization with or without irrigation installation, or ureteral pylography exclusive of radiologic service. So basically, this is the code that you will use for the work to catheterize the UO and then injecting the contrast. So that's 52005 down here. And if you look over here between 52332 and 52005, it says here, hey, 52332 includes 52005. Unless there's some extenuating circumstances, you should not be billing 52005 with 52332. Aha. So that is where you can get good information regarding what to code and what codes to build together or not build together, because ureteral catheterization is included when you put up a stent. So you would not bill for the 52005. Okay, 76000 is fluoroscopy. It's a separate procedure up to 1 hour physician or other qualified healthcare professional time. And in this case, the procedure is done in the hospital. I do not own the radiologic equipment, so that means when I bill 76000, I would only bill for the professional component. So a modifier would be needed to bill for that service. So in the end, I would put in 52332 and then 52332 and 76000 to bill for the services that I performed in doing this procedure. Wait, there's more. It is not quite that easy, right? So 52332 and 76000, and you would use the professional component only for the radiologic interpretation. Okay, so what about all that work, extra work that I did to put up a stent? And the fact that I was not successful in putting up the stent. Well, there are modifiers for that. So if you try to do a procedure and you're not successful, there's a modifier 52 for reduced services. And let me show you that right now. So if you go to the CPT AUA Coding today and you click on CPT modifiers, you get a table looking like this, a listing of all the modifiers. And if you go down to Modifier 52, you click on that. For the sake of time, I already open it. Modifier 52 says, reduce services under circumstances a service or procedure is partially reduced or eliminated at the physician's discretion. In this case, it would be because I could not get the stent up into the ureter. All right, so I was thinking, okay, Modifier 52 is probably appropriate. But for all the extra effort that I used to try to get up the stent, how do you account for that? Well, of course, there's a modifier for that. And that would be Modifier 22. It states, increased procedural services when the work required to provide a service is substantially greater than typically required. And that would be all the manipulation, the wire, using different wires, different catheters, and manipulating the catheters to try to get the wire to get into the proximal ureter. All that extra work is accounted for in Modifier 22. Now, you astute coders will be thinking, oh no, Modifier 22, that's automatic manual review, extra paperwork that you have to do. Yes, for most of you, that is the case. You would have to submit extra paperwork, and sometimes you can submit that beforehand at the initial filing of the claim, or sometimes you put in the claim and then the payer will request for additional records, and then you submit that electronically, or hopefully electronically, and not by fax or mail. But if you think about it, I was not successful in putting up a stent. So wouldn't I use Modifier 52 on the 52332 and a Modifier 22? 52332 is ureteral stent placement, and then Modifier 52 says I was not successful, and then Modifier 22 would take into account the extra work that was required to perform the procedure. But then that's counterintuitive, right? You're doing a procedure and you're saying you were not successful, so you're reducing your services, and yet you're saying you did extra work, so you need to be compensated for the extra work. So it doesn't quite make sense. And in this case, I don't know what the right answer is. I think if you put in 52332, Modifier 52, and Modifier 22, it's going to go to manual review, and I bet your payer is going to be super confused. So it may be wiser to just simply bill for 52332 with a Modifier 22. And the instances of this type of scenario occurring is pretty darn rare. And I think anybody who looks at the scenario will say, yeah, technically Modifier 52 and 22, but then in reality, you probably put in the effort to put up a stent and then much more. So if I were in your shoes, and if I were to counsel my coder, I would say 52332, Modifier 22, and also 76000, Modifier 26 for professional component only. And that's how we would code for this weird case, which I'm sure you will come across as a urologist, and I'm sure you as a coder or biller will come across. So these codes, nice and all and fairly encompassing, but it doesn't really follow reality or real life. You know, stuff is going to happen. And so how you figure out what code to use and what modifier to use, that is the tricky part, right? So you may be thinking, how in the heck did I figure all this out? Well, I'm still a student. I'm still learning, because the codes, the descriptions, and new codes are coming out. They're changing all the time. And I have been learning and studying this type of stuff for many, many years. So like I like to say that I'm a 15-year overnight success. It took a long time. And I'm still a student. I still watch seminars, read the publications, and to try to figure this out. And if you are just starting out, or if you are a little bit confused, There are courses available. The American Urologic Association has a coding course coming up in July in Las Vegas. The PRS Network, also known as the Painters, the gurus when it comes to urology coding and billing, they have an online course about E&Ms and modifiers and CPTs. In addition, there's the Urology Advanced Coding and Reimbursement Seminar occurring at the end of December and also in January of 2022 in New Orleans. So these are all training opportunities. And obviously, you can always reach out to the AUA. I believe they used to do on-site group training. I'm not sure if that's currently available. But anyway, there are a lot of training opportunities. And obviously, if you have any questions, you can always leave them here in the Thriving Urology Practice Facebook group. There are a lot of very smart and articulate coders and billers who are more than willing to help you out. So any comments and questions, as usual, leave them below. And don't forget to invite your colleagues who work in urology in the United States to join the Thriving Urology Practice Facebook group. Have a good night. Bye-bye.